My name is Emma Wilson. I am the Communications and Engagement Officer for Research and Innovation at Greater Manchester Mental Health NHS Foundation Trust. We've been hosting a monthly webinar series called Research into Practice, where we showcase one of our 11 research units each month. And we're really excited to be welcoming the Forensic Research Unit called FoRUM, who's our newest research unit here today. So without further ado, I'd like to welcome Dr Charlotte Lennox, who's a senior lecturer in forensic psychology and the director of our new research unit FoRUM, and Dr Sarah Leonard, who is a lecturer in psychology at the University of Manchester. I'm really excited to hear what they have to say. Take it away.
Thanks, Emma. And just to say thank you to GMMH for, I suppose, forging this collaboration between the university and GMMH and the creation of the most recent research unit within the trust. So thank you very much. So Sarah and I are researchers based at the university who've worked at the university's Health and Justice Research Network for a number of years, and we're going to talk a little bit about our experience of research, about research that's had a particular impact, and thinking about how we can utilise that impact in terms of developing collaborations between the university and the trust. So, if we think about why prison and forensic research is so important, really for research to truly serve society, it has to bridge that kind of knowledge creation. So in terms of university institutions creating that knowledge, it has to bridge that gap into practical application. And so where you've got collaborations between universities and clinical services, that's really where that innovation and collaboration becomes indispensable. And for us, FoRUM and the new research unit kind of embodies that. And the reason why prison and forensic research is so important, and this is a quote that kind of embodies the reasons why I think as for our perspective why we're so passionate about prison and forensic research, is that the degree of civilization in society is judged by entering prisons and forensic settings, that how we work with people in those settings and the provisions and the services that we put in place reflects our views of society, and so that's why it's particularly important in terms of prison and forensic research. So just a little bit about, I suppose, more about why that's so important. It's really important because research within prison and forensic settings has the ability to improve the criminal justice system and the justice system and forensic services. It enables us to understand the reasons why offending behaviour might arise. And so it enables us to kind of mitigate that and to put plans in place and to develop effective interventions that over the I suppose the longer term, it can improve systems. And linked to that, it's around enhancing well-being. We know there's loads of research evidence that suggests that for people who are in contact with the criminal justice system and prison and forensic services, that as a group, they are incredibly vulnerable. The kind of prevalence and rates of physical health, mental health, substance use are all much higher than the general population in the community. We also know that they often tend to have experienced very complex trauma, and it's that interplay with other kind of disadvantages around kind of poverty, exclusion, that in comparison, when you group those all together, that creates a high rate of vulnerability. And so the reason why prison and forensic research is so important is it provides us the opportunity to address health needs particularly mental health needs. It allows us to support rehabilitation and recovery. It allows us to support people to move forward and to change. It's a kind of positive outlook. And what we're trying to do is protect the most vulnerable populations. And as I said, there are high levels of need within that population. Prison and forensic research is also really important because it helps us promote public trust. We know that people in contact with the criminal justice system and forensic services, in terms of kind of media coverage and portrayal, we've got a job to do around promoting public trust. And one of the ways that research can help that is by providing accurate and reliable evidence around developing an evidence-based practice. All of these help us to deliver impact and provide strategies to improve practices which can, in the longer term, can promote public trust. And the key aim of all of our research is the development of evidence-based practice, that what happens in terms of frontline working, that's all based on evidence. And so research is really important because it informs that decision making and it informs our decisions about delivering interventions and strategies that promote the best practices. So those are some of the reasons why research in this area is really, really important. And so what Sarah and I are going to do, we're going to take it in turns, is to focus on two pieces of research that have had impact. And it's useful to say that for research to have true impact, it takes time. And that can sometimes feel sometimes a little bit disheartening for people, particularly for people working in frontline services wanting to see kind of quicker change. But this kind of gives an overview of how research can have an impact, but that sometimes we need that time for that impact to be truly embedded. So this is a programme of work which was around developing what we call is the CHAT assessment, which is the comprehensive health assessment tool. And this piece of research started back in 2000 with some funding from the Youth Justice Board, and at that time forensic mental health R&D team, which doesn't exist anymore, but they funded a series of projects looking at the health and educational needs of young people in prison. And what those pieces of research identified were that there were high rates of need, both around physical health, mental health, substance use, but also around educational needs as well. That those needs were often missed, that they were inconsistently assessed. So if a young person was in one location, transferred to another, they were often reassessed by the new unit that they were in, or if they had been discharged into the community but then readmitted, again, they were reassessed. So what we found is that often young people were having to share their stories multiple times and had this feeling of being kind of over-assessed. We also realised that when those assessments were taking place, that there were no provisions to share that information with other services. So there was an issue around the transfer of information. So from those two pieces of research, the Department of Health from 2008 to 2010 funded us to develop something that would try and fill this gap. And so we reached out to lots of expert stakeholders to think about how we could kind of solve that problem. And so what we did is we developed an assessment, a needs assessment, which captured First night concerns. So when a young person was admitted into prison, their first night needs were assessed, so things around risk and safety. And then following that, their needs were further more detailed and comprehensive assessment around physical health, mental health and substance use. Over time, there was then increasing evidence around neurodivergence, and we realised that the developing chat assessment at that time also needed to focus on areas around kind of autism, learning disability, traumatic brain injury. And so then from 2010 to 2012, NHS England funded us to develop an additional component of chat. So it then consisted of first night screening, followed by comprehensive assessment of physical health, mental health, substance misuse, and then neurodevelopmental. And so it has now 5 parts. Following that, NHS England supported us in terms of thinking about how we might roll this out nationally. And some of the key facilitators of that were that work that we did with NHS England allowed us to incorporate chat within the health and justice performance indicators. It was included in the national specification for health services delivering within prisons for young people, and it was included in the national standards for healthcare delivery for children in prison. And so those were key drivers that took our research from the development stages of developing the chat assessment into implementation. Going forwards a little bit more, NHS England supported us to do a national rollout of implementation and training with all the services, and then following that an audit to assess how well that implementation had gone. And that audit suggested that those key drivers that I mentioned around including it in performance indicators, national standards, were all really beneficial in making sure that the chat was incorporated in. Sorry, my lights are just about to go off in my office. So they were the key drivers, but still patchy implementation. In particular, some parts of the chat assessment around neurodevelopmental were more tricky for services to implement, and that was mainly because lots of services could assess the need but then didn't have the onward referral pathways, specifically for if they'd identified young people with traumatic brain injury. They didn't have those onward referral pathways, and there's still some evidence of kind of silo working, but it had, I suppose, revolutionised the process of assessing need for young people in prison, in which there was all young people have a standardised assessment. That assessment then follows that young person. So if they move around the prison estate, that chat assessment and their care plan follows them. If they are discharged into the community, that care plan is shared with their GP or their social worker or their youth offending team, health provision, so that information around that young person's health is being shared with other services. So what does that mean in terms of that's amazing, and we've got lots of evidence to suggest that their health needs are more routinely being assessed, and that information sharing is having an impact on their health needs. But kind of where might we take that further? And this is where we start to think about, can this research have even bigger impact? And what we're interested in is to try and understand whether there is the feasibility and acceptability of expanding a chat-like assessment with other areas of the prison estate. So thinking maybe about women in prison, but also within the male prison estate, there are some significant benefits of having a comprehensive health assessment on admission that then follows somebody through that journey and back into the community, because we know from lots of our other research that transitions and at the point when people leave prison is a real risk in terms of a decline in health. And so if we can support that transition and support that information sharing into the community. So while the chat project is basically it took nearly 18 years from initial conception into full national rollout, so all young people are now assessed using the chat, there's still opportunity for further impact and thinking about how we might implement versions of chat within other areas of the prison estate, and that's something that we're very keen to focus on and to particularly have conversations around how we can take that further. So I will hand over to Sarah, and she will be able to talk about some of her research and the impact that that's had.
So hi everyone, I'm Sarah. Most of my research focuses on pathways of care through the criminal justice system, and I have a particular interest in those people who are in prison who require admission to secure psychiatric services and then are often returned back to prison. So that's what I'm going to talk about today, is that body of research that I've been conducting for the last, 11 years now. So it started with my doctoral research, so part of my PhD. Prior to my PhD, I worked as an independent mental health advocate and happened to just be on a prison transfer ward. And that's what piqued my interest in what care do prisoners receive in secure psychiatric services and what happens to those individuals once they go back to prison. At the same time as that, an early study from kind of 2014 had indicated that nationally, there'd been an increase in returns to prison from secure psychiatric services. So at that point in time, we found that over 20% of all discharges from medium secure services were back to prison. So the aim of my body of research initially was to understand who is returned to prison and actually what happens to those individuals once they go back to prison in terms of access to aftercare. So the work involved 33 NHS medium secure units. So that was all the medium secure units at the time. There may be a couple more NHS ones that have popped up since. And it was a national perspective cohort study. So that meant that we looked at all discharges from all 33 medium secure hospitals over a 6 month period. And we looked at those who were not only returned to prison, but also those who were discharged into the community, just to have a look at, are there any significant differences between those individuals? And we found that there was a significant difference in terms of those people who returned to prison had a significantly shorter length of stay in secure services, were more likely to have personality disorders, histories of severe self-harm, and previous medium secure admissions. We then did a national 1 year follow-up of those individuals that went back to prison to look at what care were individuals receiving once they were in prison. So this took place in 63 prisons. If you are thinking of doing a PhD, I don't recommend doing one with this many sites. And again, what we found here was that as you'd expect, lots of people return to prison on the basis that they didn't have severe mental illness or a court process, they've been sentenced, or that they'd been treated. But one of the things that we kind of knew was present but had never been documented before is that some people were returned to prison based on the fact that they were too high risk to remain detained in medium secure services, or they simply weren't engaging. So what that represented was a significant shift in discharge decision making, or perhaps not a shift, but the first documentation of that discharge decision making. We also followed people up and found that in terms of aftercare, in terms of the right to 117 aftercare, we found that whilst people were receiving access to prison mental health teams, those people were only having their care managed through the CPA process in 22% of cases. We also found that there was a 50% incidence of people being managed on an ACCT. Over half of the individuals had stopped taking their psychiatric medication in opposition to clinical opinion. And we found that of those that were discharged into the community, released into the community from prison within that 1 year period, just 20% of those were referred to a CMHT. So it meant that what we're characterising in this study is that there's a clear issue in terms of access to aftercare and key transition points where people are losing aftercare. And this was the first time it had been documented. We then also did a qualitative study with clinicians to ask them about discharge decision making. And then collectively, these findings were used to inform the NHS England and Ministry of Justice national guidance on transfer and remittal. And also they're being used in the ongoing consultation on policy in terms of returning people to their local prison to the secure service as opposed to the prison where the person originated from, because we did find that that inter-prison transfer process was a key transition point that meant that people would lose their right to aftercare. And then alongside that, we also we're doing the traditional forms of kind of impact work, so publishing papers, presenting the findings extensively to policymakers, the Quality Network, secure services, conferences, stuff like that. So the reason I'm including that is just to give you an idea of, just because we found that there are significant issues with a care pathway doesn't mean that anyone's going to do anything about it. And that's the point of research and impact, is what do you do with those findings? So I've been quite pushy over the years in terms of making sure that people want me, people have me whether they want me or not, to be an independent advisor. So I do sit on some of the NHS clinical commissioning boards as an independent advisor, based on my research findings and the key pockets of kind of untapped areas that really need looking at in terms of national policy. At the same time as doing all of that, I also then obtained a grant from the NIHR to do another national project looking at the current discharge planning and aftercare practices across prisons and secure psychiatric services to further the area and see, what are the barriers and facilitators to effectively planning aftercare. And these findings are being used with the ongoing NHS mental health pathway workshops that are a recent body of work where we're looking at whether we can have a streamlined pathway across prisons and secure psychiatric services. And then most recently, these findings have been used within the House of Lords to challenge an amendment to the mental health bill. So I just wanted to give you a bit of a, whilst research may take 10 years and this is still ongoing, there are ways of kind of inserting your research and inserting yourselves into the key policy areas and making people listen. And then hopefully that will be, we'll see change from that. And then the plan going forward from this piece of research is to go back into the trust and develop a co-designed care pathway with staff and patients in GMMH. So if anyone here is interested in getting involved in that piece of research, do email me. That's everything from me.
Thanks, Sarah. So what we thought it would be helpful next is, obviously we've kind of give you an idea of some of the research that we've been involved in over the years and how that's had an impact, a research impact, but also kind of frontline delivery impact as well, because that's kind of really important. But what we wanted to focus on next is a little bit specifically about FoRUM, and I suppose our next steps as a very, very new research unit. So some of you might have attended our launch event. So that was back at the end of January. And one of the things that we did at the launch event was to try and understand what might be some of the the challenges, but what might be also some of the facilitators about supporting staff to be involved in research. And as I mentioned at the very beginning, it's all very well, I suppose, for us as a kind of researchers sitting at the university to be undertaking research, but actually for research to have that true impact, it needs to involve the staff in the services, either as research participants, as researchers themselves. So we just wanted to highlight some of the feedback that we got from our launch event. So one of the key things around how can we facilitate more staff involvement in research was essentially having more events like the launch event. And obviously we've got today's webinar. And so the plan for FoRUM is that we would have an ongoing and annual programme of kind of conferences or smaller events where we can encourage staff and researchers to share their research. Another area was around how can we support staff training and support to access resources. So again, thinking about how we can collaborate across trusts and the university to things like access to library resources or things like SPSS or things like that. But also about what at a university we sit on lots of knowledge in terms of kind of research design or research methods, but how we can share that with staff within the trust. Something that I would talk quite a lot about is around making sure that we're embedding PPIE, so public and patient involvement in all of our research activities. There were lots of discussions around kind of staff secondment opportunities, so how we can build that into staff's job roles in terms of giving them capacity to take part, to undertake research, thinking about continued professional development and links to the university. And I suppose what embodies FoRUM is this building of relationships between the university and the trust. Some of the challenges that people highlighted was around being skeptical about research impact, and that's why Sarah and I wanted to kind of present some of the research that has had an impact, but also caveat that with that sometimes that does take a long time, and so to think about the smaller impact that we can have rather than always thinking about, I suppose, the longer term impacts. Linked to kind of secondment, it was around research not being a core component of frontline workers and clinicians' roles, and how we might think about changing that or increasing the opportunities. One of the things that if any of you are involved in research, either within NHS trusts or the universities, will know that one of the challenges of research is that often research roles are temporary, and as research assistants, that can be a real challenge, that a lot of our research assistants are on fixed term contracts and project specific. But again, it's the possibilities of a collaboration like FoRUM between the university and the trust is thinking about how strategically between the two organisations we can support early career researchers to progress in their role. And again, difficulties in accessing funding. We know that for prison and forensic services, often we're in funding calls with lots of other competition in other areas. So we might be competing against people who are undertaking cancer research, or where they can demonstrate bigger population impact. And so it's thinking about how, as active researchers within the forensic space, about how we can maximise our opportunities to obtain funding. And I'd be interested if people wanted to kind of add some comments in the Q&A just around any additional kind of either facilitators in particular that might be useful for us to think about in terms of this, I suppose, the early stages of FoRUM, about how we can really support staff in research. And then linked to what was discussed at the launch event in January, just a little bit around I suppose, FoRUM and the research priorities and where we might be going over the next couple of years. So we did a number of sessions where people shared their vision or what they felt were the kind of priorities for the trust in terms of research. A clear one was around using technology, particularly around using virtual reality and how we might embed that both to support staff and patients within services. A real key area was focusing on specific topics. So there were lots of focus around particularly learning disability, autism and ADHD, and how we might navigate that pathway for people within prison and forensic services, and linked to what I was saying about the chat assessment. So for young people in prison up to the age of 18, learning disability, autism, ADHD, traumatic brain injury are all assessed. And what we're really keen to see is how we can kind of continue that into thinking about those neurodevelopmental pathways within adult services as well. And again, linked to Sarah's research, there was lots of discussions at the launch event around kind of pathways. And a lot of our research in the past has focused on transitions, particularly transitions from prison and some of the challenges. But it was very clear that there needs to be a focus around some of Sarah's work around section 117 sort of aftercare, but also about the links with specialist community forensic teams around ensuring that transition is smooth, but also thinking about outcomes and how as services we measure outcomes. What does success look like? What does a positive outcome look like? Because what a positive outcome might look like for one person might not be the same for somebody else. So thinking about how research can inform those kind of outcomes and kind of what are measured as outcomes of success. And finally, I just wanted to kind of focus on how we involve the voice of the lived experience. And that's really key for our research, and it's a key goal of FoRUM is to embed a PPIE kind of network within the research unit. Involvement means that research is more relevant. It makes sure it's designed in a way that works for people. It makes research information much easier to understand. And it has the ability to really influence kind of national policies. Some of the challenges that we've had over the years is that often PPIE and lived experience funding tends to come with specific projects, and so we lack that continuity of a PPIE group and that lived experience voice over the long term. But that's a key goal of FoRUM is to develop that that group across the different sectors within FoRUM. So that would include adult forensic services, adolescent forensic services, health and justice, so prisons, but also including the secure children's home as well. So making sure that each group has got that lived experience voice is really embedded within our research. As part of that, one of the things that we I suppose an early success, hopefully, is that we've applied for some NIHR research to patient benefit funding, specifically to look at the issues around embedding peer researchers. So peer researchers are people with lived experience who are working as research assistants, research associates, and actually involved in the research projects, collecting data. some of the challenges that we've had in particular with peer researchers is that there is some barriers around their lived experience, and then gaining them access to prison and forensic services. Usually it's around barriers around prison vetting, for example. And so what our aim of this research patient benefit is to try and develop a trust level, so a GMMH level, but also a regional and then national strategy, engaging NHS England, the prison service, around how we can embed peer researchers within our research, because as I said, we've had a number of barriers. And so these are some of our long-term plans for them. So they're not things that we'll be able to do kind of overnight, but this is to, I suppose, to give you a little bit of a flavour of the direction of travel as the research unit, and kind of the things that we want to focus on over the next coming years. So I can see that people have been adding in things into the Q&A, and so I've also mentioned around kind of our next steps. These are some of the things that we're going to be focusing on in FoRUM over the next couple of years.
Thanks very much, Charlie.
No worries.
So we've run over a little bit, but we've got a couple of questions here that we can start answering that were sent to us ahead of time. If anyone has any other questions that they'd like to slip in, please do. Thank you as well, Charlie, for putting, these are our contact details for research and innovation. If I think Sarah's provided the Manchester email addresses for Sarah and Charlie individually, but if you'd like to get in touch with us as a collective, we have askaboutresearch@gmmh.nhs.uk. So firstly, how do we encourage prisoners and prison staff to engage in research? Quite a big question.
It is a big question, and so I think it's I suppose it's a multiple pronged approach, really. I think being able to demonstrate impact of research, as we've talked about, it is really important for them to see why research is important, because I know that the feedback often that it feels like, particularly for prison staff who are incredibly busy, overworked, is that research can sometimes be another thing that they've got to kind of facilitate, but they don't see the impact of that. They don't see. So it's making sure that we provide that kind of feedback back to sites that have been involved in our research. So putting on kind of meetings or kind of workshops for prison staff to engage and see that kind of value of the research. That's kind of really, really important. I think there's also something around them having ownership around what the research priorities are, and I think that's what I'm keen in terms of FoRUM, is that we have kind of regular engagement events with each of the sites, so that frontline officers or frontline healthcare staff working in prisons can be involved in setting the research agenda of what those priorities are. I think that's another real impact. And as I talked about, for us, embedding a continuous PPIE group, but also embedding peer researchers is likely to then facilitate involvement for prisoners in research as well. So I don't know if Sarah's got anything else to add.
Yeah, I think on a practical level as well, you will have a gatekeeper at your prison site, so somebody that is facilitating your access. So coming up with strategies with them on how best to engage prison officers in particular. You'll likely find that clinicians will take part, but they're not often based at the prison all the time, so their lives are a little bit different. And in terms of engaging prisoners themselves, I think it can be quite tricky because there's very little incentive. We're not allowed to pay or even provide cake at a meeting or anything for prisoners as we would with anyone in a different form of community. So I think one of the key things is making sure that we're designing research that directly taps into the priorities of people that live in those environments, so that they can see the direct, maybe not personal impact that the research might have, but for others who will be in their situation in the future.
Thank you. We've had a question from Catherine. Can I clarify, are you trying to engage with researchers and trusts who give care in prisons nationally? Is FoRUM going to be a national project working together?
So FoRUM is a collaboration between the university and GMMH specifically, but we want to build connections with other I suppose other either research units, research forums. So for example, we're already aware within the Midlands prison area there is a collaboration called Lens, which is around increasing engagement in prison research. And so while we will be focused specifically, and I've just seen somebody's put in the chat about Lens, yes. So while our primary focus is around that collaboration between GMMH and the university, as a research unit, we will be building links with other groups to think about how we might develop kind of national projects, for example. And I think the other bit of Catherine's is also, is it just trust? Yes, so it's also around, we know that particularly within the prisons there are private providers of healthcare. So again, it will be building those links, and particularly for I mentioned the peer researcher project. If we're successful and get the funding from the NIHR, one of those things that we were doing is as well as trying to figure out what the process would be for peer researchers working within the trust and being involved in research, but what would that look like for private providers? So either private run prisons or where prisons have got private healthcare providers, again making sure that we can think about what the challenges might be in terms of access.
Thank you very much. I think we've answered a lot of questions. There's still some comments coming through at the moment. Thank you for giving us some information there. So thank you so much for your time and for listening today. As I mentioned, you can get in touch with Sarah or Charlotte at their University of Manchester email addresses, and with us at askaboutresearch@gmmh.nhs.uk. You can find out more about the work we're doing and our other research units as well at gmmh.nhs.uk/research-innovation. That is our sort of centre where you can see our research units, our latest news and events. You can also see our active studies finder, which is all of our portfolio and commercial studies that are currently open. It will give you the documents like the participant information sheets, flyers, posters, who we're looking for, how you can get in touch with those teams. It is all on our website there. We'd really love it if you could give it a look. But we also have social media accounts where we post some of our publications when they come out, any news that we've got going on, and any new studies that are opening. So please do have a look at what we're putting out there, and if you'd like to get involved or you have any questions, please do get in touch with us. We would love that. So thank you again very much. Thank you to Charlotte and thank you to Sarah for your time today and sharing your plans with us and your experiences, and have a lovely rest of your sunny Wednesday afternoon. Thank you very much, everybody.